when I talk about exit the Fed, that's the crypto economy, right? What does exit the FDA look like? Well, one key insight is that many of the big scale tech companies can be thought of as cloud regulators rather than land regulators. What do I mean by that? Well, first, what is regulation? People do want a regulated marketplace. They want A, quality ratings, like on a 1 to 5 star scale, and B, bans of bad actors, like the 0-star frauds and scammers and so on. And these are distinct, right? Somebody who's like a low quality but well-intentioned person is different than a smart and evil person. Those are two different kinds of failure modes you could have in a marketplace, right? Why is it rational for people to want a regulated marketplace, especially for health? Because they want to pay essentially one entry cost, and then they don't have to evaluate everything separately where they may not have the technical information to do that, yes. Right? You don't want to go to Starbucks and put a dipstick into every coffee to see if it's poisoned or something like that. You sort of want to enter a zone where you know things are basically good, and you pay that one diligence cost on the zone itself, right? Whether it's a digital or physical zone. And then the regulator's taking care of it, and they've baked in the regulatory cost into, some subscription fee of some kind, right? Mm-hmm. So the thing is, the model we've talked about is the land regulator of a nation state in a territorially bounded thing. But the cloud regulator, what's a cloud regulator? That is Amazon star ratings, that's Yelp, that is eBay, that is Airbnb, that is Uber and Lyft, and so on and so forth. It's also actually Gmail and Google. Why? Because you're doing spam filtering, and you are doing ranking of mails with a priority inbox, right? With Google itself, they ban malware links, right? So the bad actors are out, and they're ranking them, right? How about Apple, the App Store? Right? They ban bad actors and they do star ratings. When you start actually applying this lens, PayPal, they've got a reputation score. Every single web service that's at the scale of like tens of millions or hundreds of millions of people has had to build a cloud regulator. And the crucial thing is it scales across borders. So you can use the data from Mexico to help somebody in Moldova or vice versa, right? Because it's fundamentally international, right? Those ratings, you have a network effect. And there's another aspect to it, which is these are better regulators than the land regulators. For example, Uber is a better regulator than the taxi medallions. Why? Every ride is GPS tracked. There's ratings on both the driver and the passenger side. Both parties, know that payment can be rendered in a standard currency, right? If you have below a certain star rating on either side, you get deplatformed and so on to protect either a rider or a driver, and on, right? Mm-hmm. What does that do? Think about how much better that is than taxi medallions. Rather than a 6-month or annual inspection, you have reports from every single rider. Okay. Before Uber, it was the taxi drivers and taxi regulators were in a little monopoly locally, okay, because they were the persistent actors in the ecosystem. Taxi riders had nothing in common, didn't even know each other. In New York, some guy gets in a taxi, another guy, they had no way to communicate with each other. So the persistent actors in the ecosystem were the regulators and the drivers, and they had this cozy kind of thing, and medallion prices just kept going up, and this was this sort of collaboration on artificial scarcity. Afterwards, with Uber and Lyft and other entrants, you had something interesting, a different kind of regulator driver fusion. If you assume regulatory capture exists and lean into it, mm-hmm. Uber is the new regulator and Uber drivers are the drivers. Lyft is the competing regulator and Lyft drivers are the new drivers. Okay. So you have a regulator driver fusion versus another regulator driver fusion. You no longer have a monopoly. You have multiple parties. Okay. You have a competitive market. This is the concept of like polycentric law, right? Where you have multiple different legal regimes in the same jurisdiction overlapping that you can choose between with a tap of a button, right? All these concepts from like libertarian theory, like, polycentric law or catalytic, all these things are becoming more possible now that the internet has increased microeconomic leverage. And because that exit is now possible. Now, you may argue, oh, well, Lyft and Uber, they're not profitable anymore. And there's two different criticisms of them. One is, oh, they're not profitable, or, oh, they're charging too much. And I think part of this is because of certain kinds of, the regulatory state has caught up to try to make them uncompetitive. For example, they don't allow people in some states to identify themselves as independent contractors, even if they are part-time, okay? There's various other kinds of rules and regulations. In Austin for a while, Uber was even banned, what have you, right? Net though, like Uber, Grab, Gojek, Lyft, Didi, like ride sharing as a concept is now out there. And whatever the next version is, whether it's self-driving, like while it's like a very hard fought battle and the regulatory state keeps trying to push things back into the garage, this is a fundamentally better way of just doing regulation of taxis. Similarly, Airbnb for hotels. I mean, it's basically the same thing. Okay. And now Airbnb could use competition. I think that it would be good to have, like competition for them. And there are other kinds of sites opening up. But the fundamental concept of the cloud regulator, now let's apply it here. Once you realize regulation is information, the way you would set up a competitor to FDA or SEC or FAA or something like that is you just do better reviews. Mm-hmm. Like, you just start with that. That's pure information. You're under free speech. That's like still, the most defended thing, literally just publishing reviews. And not just reviews by any old person. It turns out that FDA typically will use expert panels. Where there's expert panels, it's like professors from Harvard or, things like that. So what that is this concept of a reputational bridge. What you want to do is you want to have folks who are, let's say, biotech entrepreneurs, or they're, profs like Sinclair or what have you. You do want to have the reviews of the crowd, okay? But you also want to have, especially in medicine, biomedicine, you want to have the reviews of experts of some kind. So there's going to be defectors from the current establishment, okay? Just like, there are profs who defected from computer science academia to become Larry and Sergey and whatever, they weren't profs, they were grad students, right? In the same way, you'll have defectors who have the credentials from the old world, but can build up the new. Just like there's folks from Wall Street who have come into cryptocurrency and helped legitimate it, right? Just like there's folks who left Sulzberger to come to Substack. Okay. We have these folks who, by defecting, they help, and then they're also supplemented by all this new talent coming in, right? That combination of things is how you build a new system. It's not completely by itself, nor is it trying to reform the old. It's some fusion. Okay. So in this new system, who do you have? You have like the most entrepreneurial and innovative MDs. You have the most entrepreneurial and innovative professors, and you have the founders of actual new products and stuff. And they are giving open source reviews of these products. And they're also building a community that will say, look, we want this new drug, or we want this new treatment, or we want this new device, and we're willing to crowdfund 10,000 units. So please give us the thing, and we'll write a very fair review of it, and we'll also all evaluate it as a community and so on. So you turn these people from just passive patients into active participants in their health. That's the community part, and they've got the kind of biomedical technical leadership there. Now, what is the kind of prototype of something like this? Something like VitaDAO is very interesting. Things like Molecule DAO are very interesting. It'll start with things like longevity, right? And why is that? Because the entire model of FDA, this 20th century model, is wait for somebody to have a disease and then try to cure them. Okay. Versus, saying an ounce of prevention is worth a pound of cure, right? Why are we not actually tracking folks and getting a constant dashboard on yourself so you can see whether things are breaking, and then you deal with it just like you've got server uptime things. You don't wait necessarily for the site to go down. You start seeing, response rates are spiking. We need to add more servers, right? You have some warning. Okay. Even 10 years ago, there's this article called The Measured Man in The Atlantic, where this guy, physicist, Larry Smarr, okay, what he was doing is he was essentially doing a bunch of measurements on himself. And he was finding that there were predictors of inflammation that were spiking. And he went to the doctor, showed the charts, and the doctor was like, I can't do anything with this. Mm-hmm. Then it turned out to be an early warning of like a serious condition. And he had to, I think, go for surgery or something. And he was starting to think, well, look, the way that we're doing medicine right now is it's not quite like pre-germ theory of disease, but it is pre-continuous diagnostics. Okay. Continuous diagnostics, just to talk about this for a second, this is, I mentioned one angle on which you go after FDA, which is like the better phase 4, right? I've mentioned the concept of better reviews in general, okay? I mentioned VitaDAO, which is like a community that is going after longevity. Let's talk about continuous diagnostics. So basically, we know better what is going on in Bangalore or Budapest than in our own body. That's actually kind of insane to think about. This stuff that it's all the way on the other side of the world, 10,000 miles away, but, a few millimeters away, you don't really know what's going on, right? Mm-hmm. And that's starting to change with all the quantified self devices, the hundreds of millions of Apple Watches and Fitbits and stuff, right? You're also starting to see continuous glucose meters, which is very important. They're starting to give you readouts. People are seeing, wow, this is spiking my insulin, or rather, this is spiking my blood sugar. And it might be something you didn't predict. It varies for different people. For some people, banana isn't a big deal. For others, it's actually quite bad for their blood sugar. what happens when you extend that? Well, about 10 years ago, a guy, Mike Snyder, professor at Stanford, did something called the integrome, where he just threw the kitchen sink of all the diagnostics he could at himself over the period of, I think, a few weeks or a few months. I forget the exact duration. And he's able to do things where you could see during that period, he like got a cold or something. And you could see in the expression data, the gene expression data, that he was getting sick before he felt sick. He could also see that something about that like viral infection, like made him develop diabetes-like symptoms, if I'm remembering it accurately. So you could see, oh, wait a second, these are things that are that I can see in my readouts that I would only have the vaguest interpretation of as like a human being, right? And moreover, he could take, I don't think he did this, but if you took treatments, if you took drugs, right, you could actually show what your steady state was if you tracked over time, show what your disease state or sick state was, and then this drug pushes you back into non-disease state. You can actually get a quantitative readout of what, like steady state was, right? So that, and that steady state, your expression levels across all these genes, your small molecules, basically everything you can measure, that's going to vary from person to person, right? What's healthy and natural for you may be a different baseline than for me. For example, people who are South Asian or have dark skin tend to have vitamin D deficiency. Mm-hmm. Why? Because we need a lot of sunlight. So often inside you're tapping on your screen. So what do? Take like actually significant vitamin D infusions. Okay. That's like a small example of where baselines differ between people. Okay. So continuous diagnostics, what could that mean? That could mean, it's things like the continuous glucose meter, it's quantified self, it's like continuous blood testing, right? So you have a so-called mobile phlebotomist. This is something which phlebotomist takes blood, right? Mobile phlebotomy would come to your office, come to your remote office. This is a great business for people. I think, you can revisit this in 2022. People tried this in the 2010s, but I think it's worth revisiting. Mobile phlebotomist comes every week or every month, takes blood, runs every test, right? Maybe that's, a few $1,000s a year, maybe eventually gets to a few $100s a year. And that's expensive in some ways, but boy, that's better health insurance in other ways.
Yeah, it's amazing. So there's a bunch of companies that do this, and I actually would love to learn more about them. One of them is a company called Inside Tracker that sponsors this podcast. They do that, but the reason I really appreciate them, they're the first ones that introduced me to like how easy it is, but it's also depressing how little information, exactly as you beautifully put once again, how little information we have about our own body in a continuous sense.
Yes.
And actually, also sadly, even with Inside Tracker, as I collect that data, how not integrated that data is with everything else.
Right.
If I wanted to opt in, I would like, I can't just like riffing off the top of my head, but I would like Google Maps to know what's going on inside my body.
That's right.
Maybe I can't intuit at first why that application is useful, but there could be an incredible, like that's where the entrepreneurial spirit builds, is like, what can I do with that data? Can I make the trip less stressful for you and adjust the Google Maps thing kind of thing?
That's right.
Yeah.
So, I mean, one of the things about this, by the way, is because there are so many movies made about Theranos, okay, that's one of the reasons why people have sort of been scared off from doing diagnostics to some extent. Okay. Why? Because VCs are like, oh, is this another Theranos? And like the diligence and everything, everyone's looking at it. Oh, blood testing, 1 drop of blood, huh? Hurts with recruiting. Essentially, a lot of the media and stuff around that basically has pathologized the thing that we want to have a lot more entrance in, right? Now, one way of thinking about it is FDA has killed way more people than Theranos has. All right, way more. Just take drug lag alone, okay? Whenever you have a drug that works and reduced morbidity and mortality after it was actually generally available, but was delayed for months or years, the integral under that curve is the excess morbidity and mortality attributable to FDA's drug lag. You could go back and do that study across lots and lots of different drugs, and you probably find quite a lot. Alex Tabarrok and others have written on this, right? Daniel Henninger has written on this, okay? That's just like one example. I mean, I gave the pandemic example, the fact that they held up the EUAs for the tests and didn't do challenge trials. That's like, that's like 1 million American dead that could have been orders of magnitude less if we had gotten the vaccine out to vulnerable populations sooner, okay? So you're talking about something that has a total monopoly on global health, and you can't know what it is without that unless you have zones that are FDA free, but that have some form of regulation. As I mentioned, it's a V3. It's not going back to zero regulation, everybody, man for itself, but it's a more reputable regulator, just like, Uber is a better regulator than the taxi medallions, right?
Yeah, I mean, you're painting such an incredible picture. You're making me wish you were FDA commissioner. But
there are a bunch of people who tweeted something like that after the, with the pandemic. Whatever. Go ahead. Yeah.
Is that possible? Like, if you were just given, if you became FDA commissioner, could you push for those kinds of changes, or is that really something that has to come from the outside?
The short answer is no. And the longer answer, meaning
that'd be funny if you're like, the short answer is no, the long answer is yes.
so basically, see, a CEO of a company, it's very difficult. They can hire and fire, right? Mm-hmm. So in theory, they can do surgery on the organism. And Steve Jobs took over Apple and was able to hire and fire, raise money, do this, that. He basically had root over Apple. Like, he was a system administrator, right? Mm-hmm. He had full permissions. Okay. As FDA commissioner, you do not have full permissions over FDA, let alone the whole structure around it, right? If you're FDA commissioner, you are not the CEO of the agency. Okay. Lots of these folks there have career tenure. They can't be fired. They can't even really be disciplined. There's something called the Douglas factors. You ever heard the Douglas factors? It's like the Miranda rights for federal employees. Okay. The right to remain silent. So basically, if you've heard that federal employees can't be fired, the Douglas factors are how that's actually operationalized. Mm-hmm. When you try to fire somebody, it's this whole process where they get to appeal it and so on and so forth. And they're sitting in the office while you're trying to fire them. And they're complaining to everybody around them that this guy's trying to fire me, he's such a bad guy, blah, blah, right? And everybody around, even if, they may think that guy is doing a bad job, they're like, wait a second, he's trying to fire you, he might try to fire me too. And so anybody who tries to fire somebody at FDA just gets a face full of lead for their troubles. What they instead will do is sometimes they'll just transfer somebody to the basement or something so they don't have to deal with them if they're truly bad, okay? But the thing about this is there is only one caveat, Douglas factor number 8. The notoriety of the offense or its impact upon the reputation of the agency. There's that word again, reputation and power. Mm-hmm. So the one way you can truly screw up within a regulatory bureaucracy is if you sort of endanger the annual budget renewal. Think of it as this mini Death Star that's coming to dock against the max Death Star for its annual refuel. And it's talking about all the corporate criminals that it's prosecuted, the quotas, the police quotas, the ticketing, and if they don't have a crisis, they will invent one. Just like TSA, just like other agencies you're more familiar with, you can kind of map it back. Look at the guns and drugs we've seized there. And so they have an incentive for, creating these crises or manufacturing them or exaggerating them. And if you endanger that refueling, that annual budget renewal or, what have you, then the whole agency will basically be like, okay, you're bad and you can be disciplined, or sometimes, with rare except, you can be booted. But what that means is that FDA commissioner is actually a white elephant. It's a ceremonial role, really, right? The term white elephant's basically, the Maharaja gives you a white elephant as a gift. Seems great. Next day, it's eaten all of your grass. It's pooped on your lawn. It has just put a foot on your car and smashed it, but you can't give it away. It's a white elephant. The Maharaja gave it to you, mm-hmm. right? That's what being FDA commissioner is. It's the kind of thing where and a lot of people are drawn in like moths to the flame for these titles of the establishment. I want to be head of this. I want to be head of that, right? And really what it is, it's becoming head of Kazakhstan in the mid-1980s in the Soviet Union, the Kazakhstan SSR, right? Soviet Socialist Republic, before the thing was going to crumble potentially, right? In many ways, it's becoming, folks who are just totally status obsessed getting these positions, but a lot of the merit, all the folks with merit are kind of leaving the government and going into, tech or crypto or what have you, right? So even if these agencies were hollow before, in some ways they're becoming hollower because they have less talent there, right? So A, you can't hire and fire very easily. You can hire a little bit, you can't really fire. B, a lot of the talent has left the building, what was there. C, we're entering the decentralizing era. And D, Be like Satoshi. Satoshi founded Bitcoin because he knew you could not reform the Fed. Everybody's trying to go and reform. And the reason they're trying to reform is we haven't figured out the mechanism to build something new. And now perhaps we have that. So I've named a few of them, right? I'll name one more. Related to deliverance. Fitness is actually the backdoor to a lot of medicine. Okay. Why is that? You go to any, conference, it could be neurology, it could be cardiology. You'll find somebody who's giving a talk that says something along the lines of fitness is the ultimate drug. Maybe not today when people are saying, oh, fat phobic, whatever, but not too many years ago, you would see somebody, people saying fitness is the ultimate drug. If we could just prescribe fitness in a pill, that would improve your cardiovascular function, your neurological function, deals with depression.
By the way, in that case, the use of the word drug means medicine. So
medicine. Yeah. Sure.
Fitness is the ultimate medicine. Yeah.
Yeah. The ultimate medicine, right? So if they could just prescribe the effects of it, it's just like, boom, just massive effect, right? Like you're fit enough, you do resistance training, it helps with, preventive diabetes, every kind of thing in the world, you see a significant treatment effect. Yet your fitness is your own responsibility. You go to some gym, 24-hour fitness. What do they have? They have on the wall exhortations like your body is your responsibility, right? Am I right?
Yeah.
And, go ahead, but
no, it's hilarious. Yes.
It's funny, but it's true, right?
Yeah, it's funny because it's true.
And so your fitness, your diet, that's your responsibility. But when you go into a doctor's office, suddenly it becomes lie back and think of England. Mm-hmm. Okay, suddenly you become passive. Suddenly, oh, your doctor is Dr. Google. Well, your doctor must be a moron. You're going and trying to take care of yourself. You're Googling symptoms. Oh, how stupid you are. I have a medical degree. And that doctor, see, the thing is, if you come in and you've self-diagnosed or you've done some of your own research, if you're right, and if they've got an ego about it, they're undermined. And if you're wrong, they're like, arrogant. But either way, if they've got this kind of mindset, they have an incentive to resist the patient taking care of themselves. Isn't that the doctor's job, right? And they're kind of taught to behave like this, many of them. So what that means then is that intervention of that 15 or 30-minute appointment with the doctor, whatever drug they prescribe, better hit you like Thor's hammer to put you back on the straight and narrow. Because that's only with you for like a few seconds, a few minutes or whatever. The doctor's only with you for a few minutes. The drug is only, some drugs are very powerful, so they actually do work like this, okay? But your fitness is your own responsibility, and that's a continuing forcing function every day. And again, we get back to decentralization, right? The decentralization of responsibility from somebody thinking of themselves merely as a patient to an active participant in their own health, who's doing their own monitoring of their own health, right? And logging all of their stuff, who's eating, properly and looking at the effect of their diet on things like their, continuous glucose monitor as a V1, but other things, right? Who is, as fit as they can possibly be. Like, these are kind of obvious things, but why is this the backdoor to medicine? Because since the FDA only regulates those things that are meant to diagnose and treat a disease, all the stuff that is meant to improve an otherwise healthy person is potentially out of their purview. Supplements are one interesting aspect that they were carved out in the mid 90s, and that's why the supplement industry is big, because FDA doesn't have as tight a rein on that. But all of the Fitbit, CGM, continuous glucometer type stuff, you can crank out all kinds of things that help people get fitter, that will also actually have just general health value, but you're not, quote, marketing them to diagnose or treat, a disease. See what I'm saying? Yes. You're marketing them for the purpose of fitness. This is a market. Why? Because psychologically, people, they don't like paying to get back to normal, but they will absolutely pay tons of money to get better than normal. They'll pay for fitness, they'll pay for makeup, they'll pay for hair, they'll pay for this and that, right? So that's actually the back door, and you can do tons of things there where obviously being healthier is also protective. You can actually show the studies on this. So this way you build out all the tooling to get healthier, and that actually helps on this axis. A few other things are just kind of a U.S. medical system while I'm on it, because you got me on this topic.
I love this.
Okay. So
this is the most eloquent exploration of the U.S. medical system and how to improve it, how to fix it, and what the future looks like.
Yeah. So
love it.
So basically, part of it is decentralizing control back to the individual, right? Now, I've talked about FDA at length, but let me talk about some other broken parts of the U.S. system, right? There's like AMA, there's CPT, there's CPOM, there's this, like all these regulations, which, see, normally in capitalism, you have a buyer and a seller, right? Duh. In medicine, you have third-party regulation and fourth-party pricing and fifth party payment. Okay. So third party regulation, FDA is regulating it. Fourth party pricing, it is the CPT codes, right? Fifth party payment, it's the insurance companies. All right. And just to discuss these bits of the system, first, why are some people against capitalism in medicine? I actually understand why they're against it, because they are visualizing themselves on a gurney when they're being wheeled in, and now somebody at their moment of vulnerability is charging this insane price for their care. And many people in the US have had this horrible experience where they're bankrupted or scared of being bankrupted by medical bills. Therefore, the concept of adding more capitalism to medicine scares them, and they think it's horrible, and you're some like awful, greedy tech bro kind of thing. All right. Let me say I understand that concern, and let me tease that apart a little bit, right? Basically, the most capitalistic areas of medicine are the most functional areas of medicine. So that's, say, the places where you can walk in and walk out, okay? Whether that's dentistry, dermatology, plastic surgery, even veterinary medicine, which is not human, okay? Where you can make a conscious decision, say, okay, I want this care or I don't want this. I see a price list. I can pay cash, right? If I don't like it, I go to another dermatologist. There's few dermatological emergencies. That's why dermatologists have a great quality of life, okay? By contrast, when you're being wheeled in on a gurney, you need it right now, okay? And you're unconscious or what have you, or you're not in a capacity to deal with it, right? And so these are the two extremes. It's like ambulatory medicine, you can walk around and pick, and like ambulance medicine, okay? And what that means is the more ambulatory the medicine, the more legitimate capitalism is in that situation. People are okay with a dermatologist basically turning you down because you don't have enough money and you go to another dermatologist because you can comparison shop there. It's not usually an emergency, right? Whereas if you're coming in with an ambulance, then people don't want to be turned down, and I understand why, okay? What this suggests, by the way, is that you should only have insurance for the edge cases. Insurance should only cover the ambulance, not the ambulatory. I mean, most people are losing money on insurance, right? Because most people are paying more in premiums than they are getting out. It's just that this huge flight of dollars through the air that no one can make heads or tails out of. Oh, the other aspect that's obviously broken, is employer-provided health insurance, which just started after World War II. So, auto insurance is in a much more competitive market. You don't whip out your auto insurance card at the gas station to pay for your gas, right? You only whip it out when there's a crash, right? That's what, quote, health insurance should be. And the Singapore model is actually a pretty good one for this, where they have sort of a mandatory HSA. You have to put some money in that, and that pays for your healthcare bills, but then it's cash out of that. It's like a separate pocket, it's sort of forced savings to pay for
health savings accounts.
Health savings account, right? The thing about this is, once you realize, well, first, ambulatory medicine is capitalistic medicine, ambulance medicine is socialist medicine, okay? You want to shift people more towards ambulatory. Guess what? That's in their interest as well. Now that brings us back to the monitoring, right? The continuous monitoring, whether eventually it's Mike Snyder's Integrom, the V1 is the quantified self and the Apple Watch and the continuous glucose meters, and the VN is the Mike Snyder Integrom. There's a site called Q.bio, which is doing this also, right? Eventually, this stuff will hopefully just be in a device that just measures tons and tons of variables on you, right? There's ways of measuring some of these metabolites and without breaking the skin. So it's like, it's not, you don't have to keep breaking the skin over and over. There's various ways of doing that. So now you've got something where you've got the monitoring, you've got the dashboards, you've got the alerts, and just like this Larry Smarr guy that I mentioned, the Measured Man, you might be able to shift more and more things to ambulatory. And one of the things about this also is the medical system is set up in a bad way, where the primary care physician is the one who is not the top of their class. But the guys who are at the bottom of the pinball machine, the surgeons and the radiologists, once your stuff is already broken, okay, they're the ones who are paid the most. So a lot of the skill collects at the post-break stage, right? Where you actually want Doogie Howser MD is at the upstream stage, okay? So you want this amazing, amazing doctor there, right? How could we get that? I mentioned the app that doesn't exist, which is like a better version of the 3500B, right? Here's another app that doesn't exist, and this is one that FDA has actively quashed. Why can't you just take an image of a mole or something like that? With the incredible cameras we have, a huge amount of medical imaging should be able to be done at home, and it goes to doctors, whether it's in the US or the Philippines or India. I mean, teleradiology exists, right? Why can you not do that for dermatology, for everything else? You should be able to literally just hold the thing up and with a combination of both AI and MDs, just diagnose. That should exist, right? Answer is there's a combination of both American doctors and the FDA that team up to prevent this or slow this. And, one argument is, the AI is not better than a human 100% of the time because it's not deployed yet. Therefore, it could make an error. Therefore, it's bad, even if it's better than 99% of doctors 99% of the time. Another argument is the software has to go through design control. Okay. Now, basically, once you understand how FDA works, basically imagine the most bureaucratic, frozen process for code deployment at any company ever. And that is the most nimble thing ever relative to FDA's design review. So just to review, A, talked about how FDA was blocking all this stuff. B, talked about why ambulatory medicine is capitalist medicine, ambulance medicine is socialist medicine. C, talked about how with the diagnostic stuff, we can shift it over to ambulatory. D, talked about how there's lots of things where you could have a combination of doctor and AI in an app that you kind of quickly self-diagnose. Some of this is happening now. Some of the telemedicine laws were relaxed during COVID, where now people, a doctor from Wyoming can prescribe for somebody in Minnesota. Like some of that stuff was relaxed during COVID. Okay. There's other broken things in the medical system. I'll just name two more and then kind of move on. Okay. I mentioned like AMA and CPT. Okay.
Those are two regulatory bodies.
AMA, American Medical Association, CPT, current procedural terminology. Okay. Basically, Marx's labor theory of value, where people are supposed to be paid on their effort, right? Of course, the issue with this is that you'd be paying a physicist to try to dunk, and they'd be trying, but they wouldn't actually probably be able to do it. They'd be trying real hard, whereas you actually want to pay people on the basis of results, right? Cheaply attained results are actually better than expensively attained non-results. Perhaps obvious, okay? Yeah. Nevertheless, the way that the U.S. medical system has payouts, it's based on so-called RVUs, relative value units. And this is something where there's a government body that sets these prices, and it is in theory only for Medicare, but all the private insurers key off of that. And AMA basically publishes a list of these so-called the Cpt codes, which is like the coding, the biomedical coding of this, and what each medical process is worth and whatnot. So it's like, I don't remember all the numbers, but it's like a 5-digit code, and it's like, okay, I got a test for cystic fibrosis, or a test for this, or a test for that. God help you if your medical billing is erroneous. Why? The insurance company will reject it because it doesn't pay for that. This is this giant process of trying to encode every possible ailment and condition into these CPT codes, and that you can literally get degrees in medical billing just for this. Okay. This enormous, inefficient industry. Yeah. Okay. Like literally medical billing is a whole field. Okay.
Yeah. Now, what do you want to do when you grow up? I want to work in medical billing.
In medical billing. Okay. Where everybody's mad at you at all times.
Yeah.
Part of what happens is when you give a treatment, when a doctor gives a treatment to a patient, they can't like repo the treatment. Okay. Like a car, you sell a car, you can in theory repo the car. So the patient has a treatment. Now, what happens? Well, the insurance company, that treatment is perhaps provided, look, it's a lab test provided by a company, right? The company bills the patient. The company is supposed to charge a high price. Why? The insurance company wants it to try to collect from the patient. The patient is scared. Oh my God, they see this huge price. They sometimes don't pay. Sometimes the insurance company doesn't pay either. And when a company is stiffed by an insurance company, when a diagnostic company is stiffed by an insurance company, it has to jack up the price on everybody else, right? Everything boils down to the fact that you don't have, a buyer and a seller. The doctor doesn't know the price of what is being sold. The buyer doesn't know the price of what is being bought at the time it's being bought. Neither party can really even set a free price because there's this RVU system that hovers above. The buyer feels they've already bought it because they bought insurance. The insurance company doesn't want to pay for it. Everybody is trying to like push the price onto somebody else and, not actually show the sticker price of anything and hide everything and so on and so forth. Oh, the other thing about it is obviously lawsuits are over everything. Everybody's mad about everything. It's health. People are dying. Okay. So everything is just optimized for optics as opposed to results, right? Similarly, actually, many drugs are optimized for minimizing side effects and optics rather than maximizing effects, which are totally different criteria, right? You might have, for example, a drug that only cures 1,000 people but doesn't have any side effects versus one that cures 1,000,000 people but that has 10 really serious side effects a year, right? And the second one would probably not happen because those side effects would be so big. Okay. How do you attack this? I name a few examples, but I actually think the reform is going to come in part from outside the system. In particular, India is coming online. Okay. Why is that important? Well, you may have encountered an Indian doctor or two. Mm-hmm. Okay. Maybe an Indian programmer, one or two. All right. Mm-hmm. And I do think telemedicine could explode, right? Where you could have an Indian doctor, in India, and there's a US doctor, okay, who's like a dispatcher. Mm-hmm. You see what I'm saying?
Yeah.
They've got all these other Indian doctors behind them. They've got a telemedical app, and you are now doing something where these relatively inexpensive Indian doctors who are vetted by the American doctor or the doctor in the jurisdiction with a license become the back-end doctors of the world. To some extent, this is already there with teleradiology and other kinds of things, right? But now that you've got literally like 1 billion Indians who've just come online, okay, you have this huge pool of folks who have a different attitude towards medicine. For example, it's a lot more cash payment over there. For example, India is big on generic drugs. For example, during COVID, it had something called Arogya Setu, which is a national telemedicine app. Okay, the US wasn't able to ship that. In some ways, India's digital infrastructure, again, you'll have to read a post called The Internet Country by tigerfeathers.substack.com, and you'll see that actually India's national software infrastructure is surprisingly good. It's not as good as China's in some ways, but it's like better than the US's, which is like healthcare.gov and like non-existent. It's like kind of impressive how good some of India's software is. The fact that it exists is good. So you have all these new doctors coming online. India cranks out generics, right? Telemedicine is now more legal in the US. And you have cash payment in India, right? And in a lot of other places. You don't have the whole insurance, employer health thing. And this market is growing. So you could have a sort of parallel market that starts evolving, right? Which is, and people are already doing some medical tourism, and I think that's another exit from the FDA. You have a parallel market that starts evolving that just starts from fundamentally different premises. It's just cash for everything, right? There's downsides with cash for everything. There's a huge upside with cash for everything. Cash for everything means you get customer service from the doctor. It means the prices are actually visible. It ideally pushes you, again, towards more ambulatory medicine rather than ambulance medicine. It is monitoring, constant monitoring with the quantified self and whatnot, as opposed to just let your system fail and then wheel you in, right? There's a reputational bridge because now we've had a couple of generations almost of Indian doctors in the US. So people know that there's some very competent Indian doctors. They're a good chunk of AMA. And so they can sort of lobby for this. And you have plenty of Indian engineers. Now, I'm not saying India alone is a panacea, but I do think that this is a large enough parallel market to start doing interesting things.
And you could see sort of medical tourism, medical migration to where it gives India an opportunity to basically let go of the constraints of the FDA.
Yeah, because
and innovate aggressively and I mean, it's just such a huge opportunity to define the future of medicine and make a shit ton of money from a market that's desperate for it in the United States because of all the regulation.
That's right. And I think basically it's something where the reason it needs
and
to
that would fix the FDA. Sorry to interrupt.
Yes. We fix the FDA by exiting the FDA,
yeah.
right?
And then the FDA would dry out and then it would hopefully...
It might reform. It might dry out, right? And this is, why people are, for example, they're traveling across borders, they're getting orders from Canadian pharmacies, a lot of this type of stuff, we can start to build alternatives, right? I mean, India's generic industry is really important because it just doesn't enforce American IP there. So generic drugs are cheaper, right? And it's quite competent. It's been around for a while. So there's enough proof points there where, again, I'm not saying a panacea. It's going to be something which will require like American and Indian collaboration. I think there's going to be a lot of other countries and so on that are involved. Mm-hmm. But you can start to see another pole getting set up, which is a confident enough civilization that is willing to take another regulatory path, right? and that is in some ways doing better on national software than the US is, and it has enough of a bridge to the US that it can be that simulation which you need, which is kind of something that outside poke.